First of all, I'd like to thank Dr. Ogret and Professor Aydin for inviting me here, my first visit to Turkey. Are you sure you can hear me? Yes. I would also like to thank Dr. Yüksel, who has translated all my slides into Turkish. I'm going to talk about maternal rejection of the infant and the status of the concept. And first of all, I'd say this is a review of approximately 600 works, and I want to make it clear what I'm covering and what I'm not covering. It is not about the normal mother-infant relationship. It's not about child abuse and neglect, even though these are consequences of the bonding disorders. It's not about emotional abuse, as it occurs in older children. It's not about the parental bonding instrument, which is about the retrospective, the memories of childhood. It's not about the infant-mother attachment, which is a completely different phenomenon. It's not about prepartum bonding, even though the bond with the unborn child is the beginning of the bond with the newborn. And it's not about the rejection of older children. And finally, it's not about mild disturbances, which are quite common. About 10 or 15% of mothers are disappointed in the delay in experiencing maternal feelings. It is about severe disturbances. Now, first of all, a word of history. This slide shows you the monastic library, the monastery library in Kremsmünster, Austria, which has one of the very first journals, a complete series of the original journals written in 1680 to 1720, to be found in this library. And at a very early stage, really in the 1700s, in the 18th century, it became apparent that there were severe problems in the relationship between mothers and infants. And this is an example of it. This is a child that is starved to death in Fulda, that's in Germany. Died at the age of 6 months. That's all right in Turkish, it's coming across well in Turkish. Weighing only 6.5 pounds, weighing the same as a newborn infant. And his mother completely lacked human sympathy. And she threatened to kill one of her children who tried to feed this baby with milk. And it was rumored that earlier children had died the same way. And the necropsy showed no trace of fat and the gut completely empty. Now that's not a very rare phenomenon. There are about over 70 cases in the literature of children who have been starved to death. And the first report was from this Büttner in an enormous survey of infanticides in Germany, and 3 who were starved to death. And another German author, Becker, in Düsseldorf, collected 13 cases from quite a small region of Germany. And I've personally seen a case in England of a child who was starved to death, weighing about 12 pounds, when 11 months old. Now, most of those are pathology reports, and they don't have information about the mental state of the mothers. But it's almost certain that the problem there is of profound hatred and rejection of the child. Now the next event in history history is in 1919, Oppenheim wrote a paper about 5 mothers who hated their children. 3 of them were infants. And he used the term misopädie, which means hatred of children. Then Luft, in 1964, wrote a study of 44 mothers with postpartum depression, and he drew attention to the feelings of alienation from the infant, which he considered to be a disturbance of the instinctive bond between mother and child. And all those early reports were German. But when I entered mother-infant psychiatry in 1975, almost the first patient that we came across was a mother who said that she hated her child. She actually, a very ugly phrase, she said she hated its guts. And we struggled with that problem for 3 years. She had electroconvulsive therapy, she had every known antidepressant treatment, she had expert psychotherapy, she had marital therapy, she had inpatient treatment, she had day patient treatment, and after 3 years, the general practitioner, the family doctor, said, the psychiatrists don't know what they're dealing with, and that was true. And there's nothing that can be done about it. And that was not true. Because a clinical psychologist called Eileen Briley came one day and she said, I know what this is. And she took over the treatment, and with 4 sessions, 4 one-hour sessions of play therapy, the mother formed a normal relationship with the baby, and her depression completely evaporated. It was an amazing demonstration of the power of a psychological treatment for a psychological disorder. And we published that case, Brockington and Riley, in 1984. And in 1996, I published Motherhood and Mental Health, which is a general review of mother-infant psychiatry. And it contains a chapter, chapter 6, entitled The Mother-Infant Relationship. 20,000 words, 140 references, which is the only complete description of this problem of the maternal rejection of the child. I updated that for an article in Psychopathology in 1911, and I've updated it again now in an article which has just been submitted. So what are we dealing with? What is this thing? Maternal rejection. You can argue about whether it's a disease or a dysfunction or a disorder or a matter of clinical interest. Those are all quite superficial ideas, those. It's a phenomenon, it's a thing, it's an entity. It's something inside the mother. It's a morbid phenomenon, because it causes immense suffering both to the mother and to the child. It's a clinical phenomenon, because these mothers come and ask for help. They come to mother-infant psychiatrists and say, help me with this problem. So it's really a morbid and clinical phenomenon. Now, scientific medicine is concerned with morbid clinical phenomena, and this is what we do, the routine way of dealing with them. First of all, the description, the naming, the definition, the identification or diagnosis, and then the studies, the measurement of it, the frequency, the prognosis, the effects, the causes, moving on to prevention, intervention, treatment and prevention. It's a very extensive schedule of activities which we undergo whenever we are dealing with morbid clinical phenomena. So I'm going to go through those in respect of this maternal rejection. First of all, description. One of the problems in this area is that there are only about 70 described cases in the literature, and 25 of those are in that chapter which I wrote in 1996. Very few descriptive accounts have been given, and I think that's one reason why it's so poorly recognized, even by perinatal psychiatrists. So here I'm going to give you now an illustrative case. This has not been published. The mother was a doctor's wife. She was also had a very good job in the health authority at a high level in organizing the health authority in the region. She was a highly responsible person, and she was already the mother of a delightful 3-year-old girl to whom she was devoted. And when she became pregnant again, she wanted another girl. And when she found that it was a boy, she began to feel negative about the pregnancy. And she buried herself in her work, and she ignored the pregnancy. She had an easy labor, but afterwards she felt empty and disappointed. This is a very mild disturbance. And she said, I didn't want to think about the baby. And then she became quite depressed. She had lost her weight, memory difficulties. In spite of breastfeeding, she got no enjoyment from the baby. And she said, it's his eyes. I can't look at him. I don't know why. I feel quite cold and empty to him. He's just a baby that needs looking after. At times I dislike him. Although he was an easy baby, he made her angry. And she would have to leave him for several minutes while she tried to maintain control. She shouted at him several times, and she shook the pram. She was referred to our service. There's something else here. And she also said, I don't know if I put it on the slide, but she also said that she had a wish to leave him at a shop and just leave him there. But she was admitted to the service, and as an outpatient she made no progress, and then she was get to the day hospital, she made no progress again. And after several weeks, we admitted her to the inpatient unit, where she had very intensive therapy, play therapy, and what helped her more than anything else was bathing with the baby. And that's something which they use in France, is bathing with the baby. And that seemed to help her. And then she bonded with the child, and she loved the child, but she remained depressed for quite a while. So that's an example of quite a severe bonding disturbance. Now what about the name? Now you see I use the word bonding disorder. It's very nice, it's simple. It's used a lot by the public in Britain. The mothers in the community understand what you mean by a bonding problem. But it tends to get into, professionals don't like it because it seems to recall the work which was done in the 1970s about the critical period in the development of the bond, which was thoroughly discredited in the 1980s. And professionals tend to prefer the term attachment, which is the same metaphor, it's a very similar term. The problem with that is that it tends to get confused with the infant-mother attachment, which is a different phenomenon and much later. In motherhood and mental health, I use the phrase severe mother-infant relationship disorders, but I realized that a lot of American psychologists use the term mother-infant relationship disorder for things like over-involvement, which is quite a different problem. Now, what is it we're really talking about? We're talking about something which happens within mothers, which enables them to care for infants whose demands are incessant, day and night, every day of the week, and for a long time without any much return from the infant. The infant doesn't begin to smile for 3 or 4 months. But something happens in the mother which enables her to do that. And I think probably it ought to be called maternal love. It's not a very scientific term, but that's what it's really about. And with this rejection, it's the opposite of that. The maternal love is on a continuum. I mean, there are degrees of maternal love. And at the other extreme, there are mothers who feel nothing, who feel hostility, who hate the baby. And the extreme manifestation of that is the phenomenon of the wish for cot death. Because cot death is the worst calamity that can happen to any woman. It's one of the worst catastrophes that can happen in human life. And yet, I've heard on a number of occasions mothers saying that they were hoping for a cot death. And I think, does that not bring home to you the suffering of these mothers? That they should say something like that. So it's about that emotional response to the child. But there is another emotional response. You know, the lack of any feeling and the hatred of the mother leads to neglect, leads to emotional maltreatment. But there's another emotional response, and that is anger, pathological anger. And most rejecting mothers share that as well, and that tends to lead to physical abuse. Now, as a definition, in our paper which we wrote in 2006, we defined 2 grades. Threatened rejection, where the mother really has an aversion to the child and would like the care of the child to be taken over temporarily. I think the mother I illustrated to you this a few moments ago was really a threatened rejection, but on the edge of established rejection. The established rejection, there is hatred, there is a wish for cot death, there is a wish not to care for this child at all, there's a wish for the child to be taken away permanently. Those are the definitions. Now I need to say something about the relationship to depression, because I think quite a lot of perinatal psychiatrists tend to regard this as part of this syndrome of postpartum depression. Now that is a very bad idea, because for all sorts of reasons. Because this phenomenon of emotional rejection has a different time course. It's sometimes much more severe than the depression. Sometimes mothers are not depressed. They rejected a child, but they're not depressed at all. And we found in a study we did in New Zealand, Anglo-New Zealand study, that about a quarter of mothers with the severe bonding disorder were not depressed. And it has a different response to treatment. There have been several studies which have shown that treatment of the depression does not cure the bonding disorder. There's a study from Iowa. The bonding disorders often require specific therapies. And only a minority of depressed mothers have a severe relationship disorder, many very depressed mothers have a perfectly normal relationship with their child and make tremendous efforts to care for the child in a loving way. It's not fair on depressed mothers to call this part of the syndrome of depression. It increases the stigma of postpartum depression. Now I'm going to move on to diagnosis and measurement. This slide shows the autumn in Britain, in some places. There are quite a lot of questionnaires now. The first one was introduced by Muller in America, Maternal Attachment Inventory. Then John Condon in Adelaide, a great pioneer of this area of psychiatry, developed an attachment scale. And a Japanese scale was developed by Noara and Nagata. And then in 2001, we developed the postpartum bonding questionnaire. And then in 2005, Taylor developed a much simpler one based on visual analog scales. So the postpartum bonding questionnaire has been translated into Turkish. I think I probably got the pronunciation wrong, but it's Dr. Tigasin translated it. I think there are quite a number of people who have got copies in Turkey. Now, I say something about the postpartum bonding questionnaire, which has been used a bit more than the others. And I think Condon's scale is a very good one, but it hasn't been validated. We developed this in Birmingham with Dr. Oates at the Open University. It has 25 items. We did a factor analysis, principal component analysis, with 4 factors. And the second factor of rejection and anger, which has 7 items, is particularly important in recognizing these severe disorders. It's quite useful. This is the validation. It was actually, we did quite an enormous study in New Zealand. We had 125 2-hour interviews. That's a good validation, but it's not validating its observations. The gold standard is observation. But at any rate, it is better validated than the others. And it's very sensitive to recognize severe anger, established rejection, and threatened rejection. So I think it's quite useful as a screening instrument. But there are other ways of researching this. There's, the Rutter team, Hansby is working with Mike Rutter, suggested an alternative approach based on expressed emotion. Just get the child, get the mother to talk about the child for 5 minutes and then count all the positive and negative statements which are made. I think this is a very useful method. And that's been used also by Zena, an American child psychologist, using in the model of the child interview. Now we also, in Birmingham, developed an interview starting in 1992. So it was developed over a 22-year period. And in 1998, we had this international workshop. We had delegates from China, Peru, India, Germany, and Finland. And we developed what was then called the Birmingham Interview for Maternal Mental Health, the Birmingham Interview, a 2-hour interview covering the whole area of mother-infant psychiatry, beginning with the acceptance of pregnancy, the psychology and psychiatry of pregnancy, delivery, parturition, and then the postpartum period, and the mother-infant relationship. Now then, a couple of years ago, we had another conference, this time workshop. This was in Stafford, so it is now called the Stafford interview, because Stafford funded it. And again, it was international. We had, this is an English lady from Sweden originally, India, Egypt, Italy, Spain, Mexico, and Australia. So we had a lot of talent there, and a workshop is a good way of developing research. 12 hours of really solid work done by a small group of people with a lot of experience, and we improved the interview. And the Stafford interview, I think Professor Iden has a copy of that. I'm sure that, and have you got a copy? Yes. Of course, all the interviews can be improved, but that's a good interview. And the section on the mother-infant relationship is important if you are establishing this diagnosis. Other methods of assessment, there are various nurse rating scales which are useful if the mother is admitted to a day hospital or an inpatient unit. There are brief play videotapes. They've been used a great deal in studying normal mother-infant relationships. Whether they're adequate for these very abnormal relationships, we don't know. There's a bit of a worry, really, that 5 minutes is not long enough, really, to find out what's going on. And I personally think that the best method of study would be prolonged observation, as suggested by Mary Salter Ainsworth, the person who developed the strange situation test. But she recommended narrative observation for 2 to 4 hours. That has never been done with these mothers, never. But that would be the way to study this problem. Now finally we're entering the 21st century now. And that is the neuroscientific study of the parental brain. This is done mainly by FNMR, functional nuclear magnetic resonance. There have been a lot of studies, mainly in the United States, Oxford, and also in Japan. And they've made a lot of progress in determining the complex development of when a mother looks at a picture of the child or listens to a crying child, what happens to her brain? Starting with the orbital lobes and frontal lobes, going into the cingulate gyrus and involved in the amygdala and various parts of the brain. Americans have begun to think now about studying depressed mothers, but nobody has studied mothers with bonding disorders. And if you've got access to FNMR, that is the way ahead, because then it will become, instead of being just a concept at the behavioral level, it will be a concept at the neuropsychological level, at the neuroanatomical level. And even a single case would be informative. You see, these mothers do extremely well with treatment, so that you can study a mother when she hates her child, and after treatment, a few weeks later, when she loves the child. That would be a big step forward in psychiatry. And now, frequency. I like to show these slides, but I'm talking to medical students. I show these slides to show the advantages of involving yourself in international research. This is Patagonia, Liao Liao. Let's talk next about frequency. Rejected children are common in child psychiatry. There have been 4 studies here showing really quite high rates of rejection. I particularly value the Mannheim study, enormous German study. And they found that 13% of children aged 6 to 8 years of age, 6 to 8, have been effectively rejected emotionally by their mothers. It's a very high rate. And perhaps that's because a vicious circle develops between the mother's dislike of the child and the child's dislike of the mother, and the bad behavior gets worse and worse. But of course a vicious circle can also exist in infants, if infants are very difficult. But the rates are much lower than that. In the Anglo-New Zealand study, we very carefully measured the rate. There were over 200 mothers, 100 in Birmingham and 106 in Christchurch, New Zealand. All of them had been very thoroughly evaluated clinically by ordinary clinical methods. And in addition, all of them had the 2-hour Birmingham interview. And Hetty Ocamp, a very bright clinical psychologist, flew over from New Zealand, and she and I worked for a fortnight, poring over all this data, making our decisions about the diagnosis, and then arguing about any differences, reaching consensus diagnoses. And we found that out of these 200-odd patients, 30 had threatened rejection, and 22 established rejection. And then I also show you the figures for severe anger, which are rather comparable. That's a very high rate. You know, that's 25% of mothers referred to specialist services. It's a very high rate. I don't know if I've got a slide here. Yes. No, I haven't. But that has been confirmed at least 6 or 8 times now in all sorts of different centres. India, Japan, Hong Kong. They've all confirmed these high rates to be found in services which specialise in mothers and infants. Now, a rate of 25% in mothers who reach our services is equivalent approximately to 1% in the general population, because 5% of mothers reach the services. 5% of mothers who give birth are ill enough to be referred to these services. But in the last few years, a considerable number of studies have appeared which give some kind of estimate of the frequency in the general community. I'm picking up 2 here. In Japan, I think this is Kitamura's group in Tokyo, found that 5 out of 364 mothers had a total score on the PBQ, postpartum bonding questionnaire, of high enough for established rejection. That figure, that's 1.4%. That would be a slight exaggeration because of false positives. Then in Sweden, a Swedish study found that 727 mothers had scores on factor 2, indicating established rejection. That's a bit below 1%. I think the available evidence at the moment, based on self-rating questionnaires, is about 1% of mothers are affected. Does that seem a very low figure to you? How does that seem to you, 1%? It's much higher than fearful psychosis. That's 1 in 1,000. 1%. This is a view of New Zealand, actually. Now, I'm going to talk a bit about the causal factors. Research is at a very early stage. The classic study of mothers by Leifer in 1977 started to talk about prepartum bonding, and there has been a lot of work in the USA, especially by American nursing staff, about the bond which the mother forms with the child in the womb before its birth. Certainly that is related to the bond later. after the birth. It is a predictor. That's been confirmed many times. Now, unwanted pregnancy is probably an important factor. Unwanted pregnancy is an enormous problem all over the world. I've listed there some of the countries which have acknowledged what a severe problem it is not to want a child. Is Turkey on the list there? No. I don't know what your feelings are about that in Turkey. Turkey has rather strict abortion laws. I understand that it's very difficult to get an abortion after 10 weeks of pregnancy, and it will only then be possible if there's a threat to the life of the mother, something like that. I may have got that wrong, but it's relatively strict, and I think, therefore, that you probably have quite a lot of unwanted pregnancies. I'm interested in your views about that. But there's a lot of work on the bad effects of unwanted pregnancy and causing things like depression and, of course, infanticide. But most of the work had not involved measuring bonding. And that's important. And that's what I hope Turkish researchers will do. I think they're in a good position to do that, to study the effects, the long-term effects of unwanted pregnancy, the effects on prepartum bonding, the effects on postpartum bonding, the effects on child maltreatment. You know, that's a very important study. I'm going to talk about that a bit more in Istanbul next on Monday, what you might do. Now, depression is important, either a cause or effect. It is very depressing not to love your baby. At the same time, being depressed is associated, makes it more likely that you will have a bonding problem. And depression is often particularly severe in mothers who don't bond. Now, the infant has a role to play, and there's been some Turkish research here on the problem of infants with colic, because, as you know, an infant with colic screams for hours, and that's very, very difficult for a mother. It's very difficult for a mother if an infant screams for 15 minutes. If an infant screams for hours and cannot be soothed because it has abdominal pain, it's not surprising that this can lead to severe problems in the relationship between mother and infant. I've put Yalchin and Akbar did some research on this. Now, what about the mother's own experience of mothering? You'd think that a mother who didn't receive any love from her own mother would have difficulty in loving a child. Yes, but the power of that factor is reduced by the fact, as Chenny Kumar showed in a study that he carried out in 1997, that often the first baby is not affected. And do you remember that mother I described earlier, the doctor's wife? She loved her first baby. It was only the second baby that she had difficulties with. And that's a bit against a personality factor. Here's another view of New Zealand. This is the Waimangu volcanic valley. It's a very beautiful place. What are the effects on the child? Again, there is not nearly enough research on this. But there are studies, the Mannheim study is one of these, which show the effect of cognitive delay. This language development is particularly affected. And there have been several studies showing that effect. The most important effect is emotional maltreatment. Emotional neglect means that the mother is emotionally distant and unresponsive. But emotional abuse means that the child is belittled, humiliated, subjected to hostile, sarcastic, and critical comments, is made to feel worthless, unloved, unwanted, is scapegoated, ignored, exploited, or even terrorized. Interest in child maltreatment goes back to about 1980. Actually, it was discovered in 1860, but the medical profession realized the major problem with child abuse in 1980. But the idea of emotional maltreatment is much more recent than that. It really goes back to only about 10 to 15 years, and there's now much more research about that. You've got to think, really, from the child's point of view, what are the really severe disorders which we deal with in mother-infant psychiatry? First of all, the death of the mother, maternal suicide. That has a severe effect on the child, but it depends a bit on who takes over the care. And in any case, that's very infrequent. It's something like 1 to 5 per 100,000. What about puerperal psychosis? That's 1 in 1,000. 1 in 1,000 mothers. The child has to put up with a mother who is admitted to hospital every 6 years with a recurrence of their illness. But these children, this is 1%, 1 in 100, these children, they have to put up with mothers who are persecuting them. And that is a very, very tough proposition for a child. Therapy. Now I want to say something about therapy. Now, I described the therapy in some detail in that chapter in Motherhood and Mental Health, at the length of 1,000 words and with 7 illustrative cases. Where there is rejection and hostility to the child, the first question is whether or not to treat. Because a child does not have to be looked after by its biological mother. We all know that. And it's very dangerous to force a mother to look after a child that she doesn't love. So, but at the same time, the father has his rights as well. So you have to consider that whole matter very carefully, and has to be considered with the mother and the father together what they're going to do. Now, sometimes they decide to let the child go. The child will be adopted. But in most cases, the mother says, I want to try to overcome the problem. Now, if in that case you do not separate the mother and child, if you admit the mother to hospital without the child, that's a kind of holiday for the child. That doesn't address the problem at all. It merely introduces an element of phobic avoidance. You must keep them together. You treat the depression thoroughly. Always psychotherapy, antidepressant drugs, sometimes ECT. Always treat depression. And then you focus on the mother-infant interaction. And if the abuse is feared, if there's pathological anger, then that she is never left alone with the child. She is never required to look after a screaming child, to look after a child who's been difficult. And in all her interactions with the child, she's supported. Now, so far, everything I've said so far is common sense, isn't it? You can't do a treatment trial to test those things. What would the outcome variable be? Infanticide? No, it's all common sense.
It can be care as usual, which is often non-common sense.
I'm a bit hard of hearing, but I'll come to that later. But what happens then? What about the specific treatment What do you do when working with the mother-child relationship? There are really two things which have been quite thoroughly studied. One of them is baby massage, and there is a Turkish study, I think, Gura, is that how to pronounce it? It's one of the dozen studies of baby massage. And the other is the play therapy, which was what was used by Eileen Briley in that case we treated in the late 1970s. And again, there are about 8 or 9 studies of that. And that has been researched with treatment trials. Yes. Yeah, I'll show you that. That's what I've just said. Right? Play therapy. The aim is to create circumstances in which mother and infant enjoy each other. All relationships are based on shared pleasure. And all sorts of techniques have been used for that. And this is a field for future research, but a lot of research has already been done. Now, my impression is that this treatment is extraordinarily successful. I hardly remember a failure. I suppose I've seen about 120 cases of this severe disorder, emotional rejection. And my impression is that they're always successful. But, you know, you mistrust clinical impressions. I was too busy when I was in Birmingham. There were so many other things I had to do, so many other responsibilities, that I have never done the kind of follow-up study which is necessary. It should be done. But I would like to convey an optimism about this, about the treatment of this condition. I think it's important that mothers should realize that it's extraordinarily successful. You know, that a mother with skilled help can almost always be enabled to overcome this problem. And that's important because they can't see a solution. They cannot see a solution. Here's a child that they hate. They cannot imagine that they would love the child. But they do. With help, they can. Now I'm going to talk now about, finally, I'm coming to the end, I hope I'm not taking too long, about the status of the concept. This is Blarney Castle in Ireland, by the way. You've probably heard kissing the Blarney Stone, that's another word for being eloquent. Now, the concept of severe disorders, mother-infant relationship, of these bonding disorders, you will not find that in the National Classification of Diseases, which was published in 1992. It is mentioned in DSM-4 and DSM-5, but only as something of clinical concern. That doesn't matter. It doesn't matter whether, if it's of clinical concern, then it can be diagnosed and treated and researched. So I'm quite happy about that. The Americans also have the 0 to 3. Do you use that tool, 0 to 3? It's quite helpful. It doesn't specifically have a category for emotional rejection. I have tried to influence them because it's now under review, and I'm trying to get them to put that in, but at the moment you can use 0 to 3 to some extent to identify these cases. Now, in Britain, we have a thing called the National Institute of Clinical Excellence, and they have twice produced recommendations. They're about 20,000 words on, if you like, perinatal psychiatry. They did that in 2008 and 2013. 2008, they didn't even mention it, not even the slightest mention. And a backup document of 700 pages mentioned child maltreatment just once. So that was, completely unhelpful. Now, when they were revising it in 213, we tried to influence them, and they produced this statement. Recognize that some mothers with a mental health problem may experience difficulties in mother-baby relationship. Assess the nature of the relationship, including verbal interaction, emotional sensitivity, physical care. Discuss any concerns she has about her relationship with the baby, and provide information and treatment. Consider further intervention to improve the mother-infant relationship. That's feeble. It's a very feeble statement. There's no statement about frequency, there's no description of the condition, there's no details about how to treat it. All they could say about treatment was it required to be research. The Australians produced a similar report. This is 50,000 words, and Austin was the first author. And it gave more recognition to this problem. And they recommended probes, which are based on the postpartum bonding questionnaire. They devoted a few words to intervention, and their main recommendation was referral to other centres, referral to specialists. Don't get me wrong, I'm not against specialists. I'm very much in favour of people who have specialist expertise in helping these mothers. Eileen Bryony, who treated that case in the 1970s, she was just such a person. I'm all in favour of that. I'm not in favour of a separate profession, because that involves transfer of a person, of a mother, who comes to your mother-infant service and then got to be sent to another service. All sorts of delays and difficulties. Mother-infant services must be able to do it themselves. They must have in their team experts, either psychologists. We had, in Birmingham, we had an expert. She was an Afro-Caribbean nursery nurse, very gentle, sensitive, tactful person, and she was an expert play therapist. But my ambitions go beyond that. It's not just a question of these techniques being known by people working in this area. I want them to be known by the general public. I want mothers everywhere to know how to deal with this problem, how to recognize it, because mothers can help themselves. I have a doctor who writes to me in England who couldn't get any help from the services, but she read the chapter in my book published in 1996, and she cured herself. Now, when you look at what is written in these Australian and British guidelines, you suspect, as I do, that these large committees, each of them had about 15, 20 people, had not read that chapter. They did not know how to deal with this problem. Now, last couple of slides, I just want to say that there's an international position paper which we've been working on. It hasn't got a publisher yet, but we hope it will be. And we had this statement: a proportion of mothers take time to bond, but a small minority may suffer from emotional rejection of the infant, which together with psychosis and suicidal depression is in the first rank of severity in this area of psychiatry. Its long-term effects, which include child maltreatment, are the most severe of all postpartum psychiatric disorders. And that was endorsed by 68 authors from 32 countries. I'm glad to say that they included Turkish authors as well. And that's a sign, I think, of recognition. And this is my final slide. In 2011, I was asked to chair a task force on child protection and the promotion of mental health in the children of mentally ill mothers and parents. And we worked on it for 18 months. an international team from India, Egypt, Uganda, Colombia, USA, and Britain. This is quite a small team. We produced a 34,000-word report. Mario Mai said we had to reduce it to 8,000 words, which we did. And those 8,000 words included this statement: there is a pathology in the development of the mother and infant relationship even before the birth. In rejected pregnancies, the fetus may be viewed as an intrusion, resulting occasionally in fetal abuse. Fetal abuse is described by John Compton in Adelaide. After the birth, a disappointing lack of feeling for the baby, which is common in the early stages, may, in a small proportion, progress to aversion, hatred, and rejection. Maternal hostility deprives the infant of the fundamental need for loving relationships, severely impairs interaction, and leads to emotional abuse. The infant's demands provoke aggressive impulses, which, when self-control gives way, leads to verbal abuse and rough treatment. These children are at high risk of maltreatment. Now, that statement was accepted by the Executive Committee of the World Psychiatric Association, translated into many languages, and circulated all over the world. So I think that we are now getting some recognition of this problem. It is the most severe problem that we have to deal with in mother-infant psychiatry. And I've been very interested in psychosis. I spent the last 10 years working on the psychosis of childbearing. But this is a more severe problem, a more important problem, more frequent, more severe in its effects. And it's also the most specific problem. It's absolutely at the heart of the discourse, of the discipline of mother-infant psychiatry.